So for us as medical physicists, there's really kind of two main branches. You can either be in radiation oncology or people who specify more in like diagnostic imaging or maybe MRI technology. Anywhere that someone's getting radiation therapy, there can be people like me behind the scenes. We have these huge machines and all this technology, and it's a really multidisciplinary effort to get people radiation therapy.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Dr. Amanda Cherpak, Director of Clinical Medical Physics at Nova Scotia Health Authority. Amanda is also an associate professor at Dalhousie University in Radiation Oncology and Physics. She co-directs the Medical Physics Residency Program and is active in clinical projects, incident learning, and outreach with women in science and engineering. Amanda, such a pleasure to connect with you today. Thank you for chatting with me.
Oh, thanks for having me. I'm excited to be here.
So just to get going, we'd love to learn a little bit more about yourself, your background, and what you do at the Nova Scotia Health Authority.
Absolutely. Yeah. And that's a great place to start. Not many people know medical physics, or when I tell them what I do, they really don't know what my day to day looks like. I'm a clinical medical physicist. I'm from Nova Scotia, and that's where I am right now. I'm in Halifax, Nova Scotia. I have a PhD in medical physics. When we end up here in the hospital, it's usually by path of doing a PhD, and then we do a residency, similar to medical students, a 2-year residency, and then we get hired on in a clinic.
And what drove you to this field? Maybe just to start with, why did you go into medicine? What was the interest there?
So medicine always interested me. I thought I wanted to be a physician, so like a medical doctor going to med school. It was a lot of little steps, not one big step coming out of high school, deciding to go to medical physics. I knew I had an aptitude for math and physics. So I did a science degree at St. FX here in Nova Scotia. Really liked physics. And then after that, went to Carleton University, where I did graduate school. I was really fortunate to work with a supervisor, Dr. Joanna Stigler, who was a force to be reckoned with. She was a strong woman for a long time. She was the only woman who worked in her department. And I got to really see her day to day. My graduate research was very clinical. So I liked how she worked in the hospital, but still doing physics. I think a lot of people are interested in healthcare and medicine, but they don't understand the huge variety of professions that exist within the hospital. So yeah, I kind of really liked it, went on and did a residency, and then ended up here about 10 years ago.
You know, it's really interesting. A lot of guests that have sat in your chair have talked about the role of mentors, pulling them into where they are and kind of shedding new light on positions or professions or career pathways that they didn't have on their radar. So interesting to hear how that's part of what drew you into the profession. And so medical physics kind of sits at this junction, this intersection between science and healthcare. Maybe tell us a little bit more about that.
Yeah, for sure. So for us as medical physicists, there's really kind of two main branches. You can either be in radiation oncology or people who specify more in like diagnostic imaging or maybe MRI technology. Anywhere that someone's getting radiation therapy, there can be people like me behind the scenes. We have these huge machines and all this technology, and it's a really multidisciplinary effort to get people radiation therapy. So we have the radiation oncologists who are seeing the patients and determining where the tumors are and how much dose we have to give them. We have nurses following them. We have the therapists who are setting them up day to day. And we're kind of in between there, kind of assuring that all the technology is calibrated properly. All the technology is going to work the way we say it does. We also work a lot with some of our specially trained radiation therapists called dosimeters, figuring how to get the radiation into the body, but spare all the healthy tissues. We do some teaching, we do a lot of radiation protection. So we're kind of that in between the clinical side of the patients and also the day-to-day when they're coming and getting that treatment, kind of assuring that every step along the way is working properly.
And so you started out with more of a physics and science orientation, got more exposure to healthcare. And then it sounds like a little bit later also brought on a teaching element, right? You're an assistant professor. What drew you into that side of the house, into academics?
Yeah, so I was always interested in education and teaching. Certainly, earlier on in my own education, I thought maybe I wanted to be a teacher. My parents were teachers, elementary, high school. My dad was a math teacher. My mom taught grade 2. So it was kind of always in the atmosphere, this idea of teaching. And then I think later on, it kind of morphed into how everybody hates physics and they think it's really hard. And I don't believe it's hard. I believe they have maybe not so great teachers. So I was always at one, if I saw someone trying to explain something or teach something and it just wasn't getting through, I was like, give me a shot. Let me try. I really felt that I could break things down. There's no part of me that ever gets up for a presentation or a lecture where I just want to tell people I'm so smart and this is so hard and look at all this great stuff I did. Because if people don't understand what you're talking about, everyone's just wasting their time. So it was just always a real passion of mine to really be able to explain what we're doing and to communicate what we're doing so everybody can benefit from these tools that we have. So when I came here to Halifax, we have a great university here, Dalhousie. We have opportunities to teach our own graduate students, so medical physics students. We also work with the med students who would go on to become radiation oncologists, and then some other people coming through radiation therapists. So these opportunities are certainly available, and I definitely gravitated towards them and really liked them. So I kind of took on teaching part of the graduate course that we have and volunteered for some of the teaching for the other learners that we have. And it's really encouraging just, to surround yourself by younger people coming up and to really have a passion for this stuff. So it's a real bright spot in my career that I really enjoy.
It sounds like the optimal triple play for you, right? Science, medicine, and education. And you've got a passion in all of them. You mentioned earlier, Amanda, that, when your mentor first brought you into the field, it was principally male dominated. Is that still the case? I mean, I don't know a lot of women that are in physics, and it sounds like you're also involved in helping to shed more light and get more exposure for women into this field. Talk to us about that direction.
Yeah, absolutely. So the landscape now definitely looks much different than I mentioned when my supervisor started, and you're looking back to like the 80s and 90s, you might have one woman, if that, mostly male. Right now, I believe our professional organization within Canada, it's called the Canadian Organization of Medical Physicists. I think we're at about 30% women within that. So it's definitely up there right now in a department of about 16 physicists. We've got, I won't say off the top of my head, like 5 or 6 are females, so it's really growing. It's really encouraging. It's tough for women, especially if they have children. I have 2 young girls myself, and I took here in Canada, we're very fortunate to have a healthy mat leave. So I took a year off with both of my children, but I had so much support here within my department and, different people pitch in or you get people to come and cover. So there's additional challenges, but it's definitely on an upswing for sure. It's much different now.
That's encouraging. And another thing that kind of stands out for me in your career is that your entire career is in Nova Scotia. A lot of healthcare leaders bounce around. I've worked across different care settings. I think you also worked in Ottawa for a while, you mentioned, but maybe talk to us about like what drew you back to Nova Scotia and maybe a good chance to talk about what is the Nova Scotia Health Authority, which I think is relatively unique in the Canadian landscape, which sometimes from the outside in for our US or international, listeners, it seems like, healthcare in Canada is very like homogenous kind of single payer system. We actually know it's very bifurcated, and Nova Scotia is one province that I think does a really good job of a fully integrated system. So maybe tell us a bit about your journey into back to Nova Scotia and what is the Nova Scotia Health Authority.
Absolutely. And I really appreciate your assessment of that. Here in the province, we're really making huge strides to make it a homogeneous offering of healthcare, across the province. Me personally, so I'm from Cape Breton, which is a smaller part of Nova Scotia. We have 2 cancer centers here in the province, here in Halifax, and then we do have one in Cape Breton. So I feel that, I'm really fortunate to have that side of understanding that, yes, that Halifax is the capital, but, we put a lot of effort into maintaining the same standard of care in Cape Breton. And, that's where my family lives and that's where I'm from. And, I visit there a lot. So really trying to offer the same things across the province. I grew up in Cape Breton, so, smaller town. I did my undergrad university in Antigonish at St. FX, which is halfway between where I grew up and the big city of Halifax. Then I went to Ottawa for my graduate school. At the time, our graduate program at Dell was kind of just growing. It wasn't too big at that time. So I finished graduate school and my eyes were definitely open to coming back home to Nova Scotia, but not if it meant sacrificing any part of my education or sacrificing the standard of what was going on. So I wouldn't be here if if it was just because I'm from here or from my family. So when I was finishing graduate school, our chief of medical physics here, Dr. James Robar, is a real standout in the field. He's really done some incredible things, especially with research. So I got to know him later in my graduate career, and he took the time to give me a tour here and really explain what was happening. Our research program is really starting to grow. I think it, grew by several times over in the time that I've been here. So I really saw a vision and I saw the opportunity to do the things I wanted to. I saw the support, I saw the encouragement to continue my career as I wanted to. So there was no sacrifice of coming back east. Also, Nova Scotia born and bred, I have the pride of just being able to contribute to what's going on here and to grow our radiation therapy department as it has and really help bring top of the line care here was really important to me. So yeah, that's kind of the overview of how I ended up here.
Well, it sounds like Nova Scotia is lucky to have you back. And yeah, truly a lot to be proud of, I think, in the Nova Scotia Health Authority. And so maybe let's fast forward into it today. You're leading the medical physics field. And so where is this field going? Like, what are some of the transformative advancements in clinical medical physics? And really, how do these impact patient care and physician workflows?
Sure. So some of the main things that I've been involved with over the past couple of years is implementation of adaptive radiotherapy. So where we have, there's increasing computer power and technology available to us, and certainly leveraging AI-informed tools, being able to do more with the tools that we have. So right now, the way it works, it's a patient will come and we design a radiation therapy plan for them based on the anatomy that we see when they come for a treatment. And then a couple of weeks pass as we design a treatment and figure out where the beams are going to go and what we want to treat. And then they come and we deliver that plan over the course of several treatments, or we call fractions, or weeks. But now what we're able to do is each day that they come, we can take a scan, see what things look like on that day, and design a plan on the fly. So adapt to their anatomy that they have that day. So maybe they're losing weight, or maybe they're on extra fluids, or maybe their bladder is more full, or their rectum is more full. We can adapt to that on the day. So hopefully spare some organs at risk, so the healthy tissues. And there's certain sites where that lends itself better than others. And then as we do better and we can kind of be more precise and adapt on the fly, we can look at delivering our treatment in smaller treatments. So rather than have someone come for 20 treatments, if we know we can do better, spare these organs, we can deliver, maybe in five treatments. This is something we do on other machines anyway, but it just kind of opens the offering and we're able to do it with more patients that might not have otherwise been eligible. One of the tools that allows us to do this is, I mentioned, AI-informed technology. So that's a big thing in our field. So a lot of these different AI tools to help us, we have to trace out these healthy tissues. So we have to tell the computers that, this blob on an image is the bladder, and this region is a rectum, and this region is the tumor. So these AI tools can help us do this. What it does is it kind of frees us from these very time-consuming tasks. So you can do more with the resources you have and with the time that you have. So I think in the next, as we move on in years and years, we'll see these kind of tools being integrated more into treatment, to personalize the treatment that patients are getting on the resources side, to kind of offload some of these really kind of time-consuming and tedious tasks. Of course, there's a lot that will always need a human trained eye to double check, but we have a growing population, we have an aging population, and we only have so many resources, so we have to figure out how to do more with what we have. And I really think that's the way.
Is the principal modality that's being used to create the treatment plan, is it mostly CT or MR?
That's a great question. So, for example, we treat prostate patients. And when we're trying to do these high dose treatments, all those patients get an MR beforehand, and that helps the physician figure out where to treat, and they can see a lot of the soft tissues. But any of the plans that we make are based on CT because that gives us certain information, the electron density of these tissues. And that's what we need to be able to calculate dose, to be able to calculate the treatment plans. So while the MR might let us see more, we still need that CT to do the calculation. And then on the day-to-day side, we have a different kind of CT. So we can take cone beam CTs while the patient is on a treatment couch just before they get the radiation. So the patient comes in, lies down, we can take a cone beam, figure out what's going on, and then without moving them, then deliver the treatment. One of the tools that we had the fortune of being one of the first in the world to have access to is this new imaging solution by Varian called HyperSight. And what that did was it was a huge leap forward in the image quality of that cone beam CT that we get day to day. It used to be that image you would capture day to day was fine enough to position the patient, but not good enough to be able to contour tissues or to be able to see the prostate and the bladder and the rectum. But it's really unlocked that for us, which has really allowed us to do a lot more.
Well, I think, I'm an ultrasound junkie. Unfortunately, ultrasound is not heavily utilized today to guide radiation therapy, but we definitely see a lot of what you talk about in guiding other types of interventions, like, for example, HIFU, which is also used to treat, diseased tissue, and really kind of this convergence of like pre-procedure planning coupled with like real-time guidance, which is more in tune with where the patient is at that moment, and also ensuring that the actual procedure is performed as per the procedure plan in real time. So interesting to hear you talk about kind of that conversion and new technology convergence and new technology that's coming up that's fusing the ability to work both with like a pre-done MR plan maybe, and then a real-time CT.
Ultrasound has its place in radiation oncology. We use transrectal ultrasound probes for there's one version of radiation therapy we can give that's called brachytherapy. And it's where we do it a lot for gynae patients, or for our prostate patients. It can put needles into the patient and put radioactive seeds into the prostate. And that's all guided at our center with a transrectal ultrasound.
Right, absolutely. Yeah, I'm familiar with those prostate procedures in particular. Also keen to maybe unpack a little bit more on AI. I mean, I've been active in the imaging AI field for many, many years now, and I feel at some level in CT and MR in particular, kind of the promise of what AI can bring hasn't really been fulfilled because it hasn't substantially reduced the reading time in radiology and cardiology. To some level, cardiology is a little bit more ultrasound based. And, until the point that we can eliminate, for certain types of procedures, eliminate the need for a human reader, then kind of the use of AI is somewhat limited. It indicates a region of interest, maybe draws a polygon, segments the anatomy, but I think hasn't, on the diagnostic side at least, hasn't really delivered maybe its full promise. But interesting to hear what you're talking about, Amanda, in radiation therapy. It actually is a substantial time saver, right? Because it allows you to then kind of focus on specific areas that the AI has identified. Is that correct?
Yeah, I hear what you're saying, though. We see a lot of it. So the segmentation of different tissues. So the big thing that takes a lot of time is contouring for us. So I mentioned, we get a scan and you have to contour every slice of the bladder, every slice of the rectum, every slice of the target, that kind of thing. So that's where there's a lot of effort put in, I think, to different AI algorithms, and different ones perform differently. But the thing is, if it does kind of a not great job, it's almost just as long to correct what it did as it is
So the human reader to go in there and recontour.
Clear it and start again. It does better with things like, say, bone, where it's a very high density tissue compared to surrounding tissues. The current system we have is okay. The technology we have, so the Ethos machine we have, there's a new release that's just coming out, and we've been able to test a little bit, and that's really fantastic. And our radiation oncologists and our dosimeters, these are the people that do all that contouring. They're really excited to see it, because if a bladder is a bladder is a bladder, whether someone takes, 15 minutes to do it, or a computer can give you a really accurate version, you can just kind of zoom through, that's a big time savings for patients that we have. So that's really, I think, the key, the contouring step. If we get better, which it's coming, I got to see it. I'd say, this time next year, we're going to be that much further ahead. That's really the place where we can see it. And then also there's certain indications and certain tumors that maybe occur in the same similar type of spot. And, the anatomy is kind of similar in that same region. And it can kind of give us a head start on how to design those plans, and kind of figure that out. So yeah, I agree with you. We're not there today, but it's getting integrated and we're kind of understanding what it can do. And then I think we'll we'll see it really improve in the next little while.
Well, I think that feedback is really important to technologists, right? Of ensuring that actually we build technology that is truly useful for what you're trying to accomplish. Maybe as we step back and we think about this broader field of radiation therapy, where else can technology play a role to improve patient care, increase efficiency, meaning reduce procedure time and enable clinicians to do more? So it sounds like AI is one field. Is there a lot going on in maybe minimizing harmful dosing or increasing accuracy of the solutions? Where can technology help here at large?
Yeah, that's a good question. So AI, so leveraging tools like that to save time on the resources side. Also, we're really focused on being able to increase the patients and the indications where we can treat with what we call hypofractionation or like higher dose per fraction. So instead of getting someone in 20, 30 times, can we increase efficiency? Can we increase accuracy? Can we increase the quality of what we're doing so that we can give higher dose each day? Now we have to do that safely, but whatever we can do to contribute to moving there. So, we have patients that are getting treated 20 treatments. What can we do to enable bringing them down to 5? So, there's a lot of different details to that. And, I don't want to sell our physicians down the river and have everyone tell them, they want 5 instead of 20. There's a lot more details to figure out than that. But the more that we can do that, the better that we can do, with our technology. Personalization, so treating each day differently and the anatomy differently, that really helps. Also, for some of our emergency patients, we're in a lot of pain or maybe end of life, they kind of get jumbled around a lot. Like we bring them in the clinic and they go to a CT sim to get a fan beam CT, and then they maybe go to a clinic room while we plan, and then we bring them into a treatment room. So looking at ways that we can maybe bypass that initial CT. So by increasing the imaging, the quality of the imaging that we have on the units, can we enable workflows where we bring them right to the unit, get them in and out and back home in shorter time. So I think it's really important to just have these pie in the sky type ideas, and not get too caught up on step by step of, the little details, like figure out if these things work, like can we do it? Is it feasible? If it is, okay, then we'll backtrack and figure out how could we critically implement that.
I think that's great advice for a lot of our audience is medtech entrepreneurs, right? So how to think about solutioning is really first start with understanding the pie in the sky dream of the scientist or the clinician behind it, and then working back to say, okay, if that's achievable, now how do we build a more detailed plan to get there? Sometimes the devil is in the details, but at least understanding, like, could you do a high level assessment of like, is this even achievable? And often, you just need kind of that big, hairy, audacious goal to work toward. Yeah. And over time, things do turn out to become achievable as underlying technologies also help to increase the possibility of the feasibility of getting something done.
We had a research meeting just the other day, and a colleague of mine were kind of like throwing out all these different ideas. I think that were sort of terrifying other people. We're like, well, what about the appointments and the patient? And we're like, just could it work? Like in a perfect world, could this work? And if we're at a 1 and we're dreaming about a 10, maybe we land on a 5, and it's still that improvement.
And it's, it's a stepwise process. I can tell you, like, our history in ultrasound, we developed the first wireless ultrasound. And like the first question was like, can it work? I mean, ultrasound was like this big honking machine full of like buttons and cables and big processing units. And, I have one here. This was our very first ultrasound. We built this one, 2017, it came to market. It was still very big, like maybe impractically big for a transducer, but it was wireless and it had really good image quality. And we said, well, this is kind of V1. And then over time, 3 versions later, it's now something that really fits in your pocket at 300 grams. So I think that's a good, again, piece of advice for entrepreneurs is kind of start with the big picture and then iterate and figure out what are the steps to get there. Maybe let's take this in another direction. Like if we step back and you talk to think a little bit about the fact that in terms of just societal factors, like people are living longer, like cancer is becoming much more of a kind of chronic manageable disease than necessarily life-threatening. It is in many instances, of course, that too. But why does radiation oncology matter? Like how does this kind of impact the big picture of where healthcare is going, and what role should it continue to play on a go forward basis?
Yeah, that's a great question. And I mean, that's exactly the insight. People are living longer, which is fantastic, and that's the goal, but it brings in different considerations. So, we maybe 20 years ago or 30 years ago, you might only see a patient come to your clinic once, maybe twice if they develop some metastases, and that might be it. Now we can see patients 6, 7, 8 times, they're coming back. So it makes it that much more important to preserve quality of life. So we need to get the dose to the tumor to kill the tumor and, create cure. But at the same time, we'll go back to the prostate, just because it's very predictable anatomy. You have the prostate with the bladder sitting right on top, the rectum's there, the bowel is there. So it's really important, if this patient is going to live another 20, 30 years, you don't want to leave them with these side effects that really affects their quality of life. You really want to be able to spare those. And so that, the life that they're living is a good one and a happy one. Also re-radiation. So someone might get a metastasis somewhere in the lung or in the brain and we treat it, but we have to know that they might recur, or, they might be coming back in a few years. So you want to make things as conformal. You want to spare all that healthy tissue to kind of give yourself room if there's another tumor nearby in the future. So it's really that sparing of healthy tissue. So back a number of years ago, the focus might all be on getting that high dose to the tumor kind of at all costs. And our machines certainly weren't as be able to shape the doses as formally as they could now. So you might get the tumor, but you also might get, fair bit of healthy tissue. But now we really want to just cause the damage to as little healthy tissue as possible so that the patients can continue on and, we see them again and they come back. And exactly like you said, like a chronic illness, where they come in and then they go on their way and maybe we see them again. But, we'll deal with that when the time comes.
Yeah, it's been quite a consistent theme actually in this season of our podcast of this concept of patient-centered care, which you've been hearing about forever, but is really becoming a reality. And interesting to hear your perspective that much of it is driven by the fact that patients are living longer, and therefore like what we would in the past maybe consider as like a one and done, like let's do a very interventional procedure or like a very radical therapy to just like kill the disease, deal with the condition. We're saying, well, we got to balance that against the fact that, this patient is probably going to survive this, but we have to deal with everything else that comes with it, all the upstream factors. Will they be able to eat properly? How will this impact other factors of quality of life that are more than just fighting the specific disease or condition that we're dealing with? And that's interesting also to hear from someone who's coming at this much more with a science and a physics angle, right? That nonetheless kind of this concept of the patient at the center of the experience is permeating to the clinicians, to the scientists, to everyone who's involved, the technologists, maybe everyone who's involved in creating the solution to better prolong life, not at all costs, but rather at this important kind of fragile balance with quality of life as well, not just long life.
Yeah, and it's a constant reminder there, as physicists, we interact with the patient's information and, especially for these adaptive radiotherapy treatments where they're at the unit. But we're not front facing, it's the radiation therapists have to see them every day and the radiation oncologist. So it's really important that we all remember everyone's point of view. So, if there's some crazy technique that we're thinking about and it's like, yeah, but that's going to take 5 times as long. You know what I mean? Like, so it can't be these kind of patients, or we got to think about this, and that patient can't hold their bladder that long, or, it's just always a consideration. And then also, if we can increase our offering of bringing those long treatments, to fewer fractions, then, that's what the patients want as well. And it's a consideration for us too with the center we have in Cape Breton. We want to make sure that we offer whatever we can in Cape Breton, because for those treatments where patients have to come to Halifax, to me, I might say, oh, it's a 4.5-hour drive to them on a weekend, but like for patients who are sick and, maybe they're facing the last few weeks, months of their life, or just, the idea that their life is finite, they just don't want to be traveling. They want to be with their support system, so we really remember that and try to empower that center to do all that they can, so people can stay home and not have to travel too much.
Is that another direction in radiation oncology of being able to, limit or strip down the physical footprint, the capital footprint, right? The kind of basically to make these services available in more care settings, because I think in line with what you've been discussing around kind of this movement towards more patient-centered care, we're certainly seeing a proliferation of a lot of solutions that used to be buried in the hospital basement, moving to outpatient centers, moving to surgical centers, moving ultimately into the community. And so kind of moving away from this hub to more of a spoke model. Could that happen with something that's so capital, equipment, specialty intensive like radiation oncology?
Yeah, that's a good question. I'm definitely not the person to speak on, the surgical or the outpatient type things, but as far as, radiation therapy and what we offer in the two centers, there's a huge monstrous effort going on right now to homogenize things across the province. So what someone is getting in Cape Breton is the same as what they're going to get in Halifax. And that takes a lot of effort when for many years things are maybe done separately or differently. I think there's always going to be things, these really highly specialized treatments that maybe don't occur frequently enough to maintain expertise. They're always going to have to stay in the hub center, just I think for safety. But those things that we see all the time, or different scans that people need, or different routine treatments, whatever we can enable in these other centers, so people don't have to travel too far. I think the better.
Excellent. Well, Amanda, it's been fascinating to hear about your journey, your roots in Nova Scotia, coming back to it, the way you've synthesized medicine, science, education into your career, and getting really deep into the technology of medical physics, which I, frankly, didn't know that much about. So I really appreciate that. And I'm sure our audience does. And then talking about kind of where this is going from a technology perspective. So it sounds like more AI to limit the need for manual work, such as contouring, the ability to continue to decrease the dose and really adapt more of the technology and more of the delivery of these solutions to what the patient needs today in the moment, not necessarily what was prescribed in the original procedure plan. And I think that's interesting to think about that thematically across all of healthcare, even in a highly specialized field like this. If our audience want to learn more about what you do, your research, your work, where can they find out more about you?
Sure, yeah. So I'm on LinkedIn. I try to limit other social media as much as I can. So Twitter, Instagram, don't try to find me there. But yeah, LinkedIn, I encourage people to reach out if they want to connect. They can look me up there. Yeah, I'd be happy to chat or answer any other questions. They can search my name as you see it here, and you'll find my contact information.
Super. Well, I will certainly continue following you, Amanda. That's all we have time to cover today. But I'm really grateful for spending time with you and for learning so much about your field.
Thanks. I appreciate it. A lot of fun.
Yeah, and to all of our listeners, thank you for joining us for another episode of our podcast. Be sure to tune in for the next episode coming up soon. Thank you, everyone. That's a wrap.